really pleased to introduce Joel Lection to AIHI. Joel's actually been here before, a couple of years ago. At that time, I think he gave me a list of potential topics. I would have wanted him to talk about all of them, so we decided to sort of get him back again. He's a very interesting speaker, and just as sort of a background to that, he has been a consultant on pharmaceutical issues for the province of Ontario, various arms of the Canadian federal government, World Health Organisation, the Government of New Zealand, the Australian National Prescribing Service. He's a frequent outspoken critic of the pharmaceutical industry and the way that Health Canada regulates drugs. His book, Private Profits versus Public Policy, the Pharmaceutical Industry in the Canadian State, was published by the University of Toronto in 2016, and he has a new book on the relationship between the Canadian medical profession and the pharmaceutical industry, and it's due out in May 2017, so I'm looking forward to that. And today we'll be talking about expedited approval programs in the United States and Canada. Welcome, Joel.
Thank you. Thank you very much for the invitation, Andrew, and where's Kelly, for doing all the work to get me here. And you may be getting rain here, but I just had a look, and it's -8 in Toronto now, and the prediction was that today they were going to get 10 centimeters of snow, so I would rather be here at this point. So I'm going to talk about what are generally termed expedited approval programs to get drugs on the market. And expedited approval programs are those which either provide additional assistance to drug companies in the form of consultations, or that allow drugs to come onto the market more quickly than they otherwise would because they're approved on the basis of preliminary data. So that would be phase 2 trials. Drugs go through 3 phases, typically, of human trials before they come on the market. The last one, phase 3, has a few thousand people. Phase 2 is more limited. But some of these programs will accept drugs on the basis of phase 2 trials, or they have what are called priority review programs. So instead of taking the typical 300 days that it's supposed to take in Canada or the United States, it's down to 180 days. So I have no conflicts. And so this is just what we're going to go through. A quick description of what these programs are in the 2 countries, how often they're used, and whether or not they're being used appropriately, what are the safety consequences of using these programs, and finally, why are they being used more and more? And actually, I should have added on there will be a brief description of what's happening currently in Australia. So the US, having a much larger pharmaceutical industry with much more economic power than in Canada, has a lot more programs than Canada does. So these are not all of them, and I'll talk a little bit about some of the others. But you can see there, they've got priority review. That's the 180-day. Accelerated approval is where you can accept drugs based on more preliminary data. Breakthrough, again, more preliminary data. Fast track is where there's more consultations, meetings between companies and the Food and Drug Administration. And this just shows you where in the process these various programs will operate. So as you can see here, some of them operate before the actual regulatory review. In other words, when the companies submit their piles of data to the FDA. Others go through the priority one is just during the regulatory review process. Accelerated approval spans both clinical testing and the regulatory review process. By the way, anybody who wants to interrupt, go ahead, ask questions. So here we have just some more. So the Orphan Drug Act, and I believe Australia also has orphan drug legislation. This is for diseases which have an incidence, I believe in the US, of less than 1 in 10,000 maybe. Priority review voucher. This is where you can get if you produce a drug for what's considered a neglected disease, you can then get a certificate which allows you to get another drug that you've made through the approval process quicker. And in an attempt to stimulate the production of antibiotics, we have the GAIN section. I can't remember what GAIN stands for offhand, but it's because companies aren't that interested in antibiotics because they're taken for short periods of time, and if you use them properly, you would actually reserve new antibiotics and not use them very often. They're not economically attractive to companies. So this program or this policy is trying to make it more economically interesting. And finally, we have the just passed 21st Century Cures Act. This had strong bipartisan support in the US Congress, so it's not just a Republican push. And the 21st Century Cures Act is frightening a lot of people because it would significantly dilute the evidence base for getting new drugs on the market. You would, instead of randomized controlled trials, you would be allowed to use observational data. You could use patient experience information. In other words, how do people feel about the drug? What are the patient's perceptions of their improvement or side effects? That will be taken into consideration. Biomarkers, surrogate measures, a whole bunch of things that, while superficially attractive, aren't necessarily going to tell you very much about how well the drug is going to work or how safe it's going to be. And I'll give you some examples as we go through this talk. So in the US, these expedited approval mechanisms are becoming the norm. So 97 to 2012, over 40% of the drugs that the FDA approved went through the priority review process. In other words, 180 days instead of 300 days. Over half of the drugs approved in 2012, these are new drugs, what in the US would be called a new chemical entity. In other words, a molecule that had never been marketed before in any form. So the majority went through at least one expedited pathway, and we have this breakthrough designation, and although a large number of drugs were denied this designation, a substantial number were approved through it. And you can see here where these various programs are being used. So oncology is a very significant one. And again, there's a push to do this because despite advances, a lot of cancers are still pretty bad news. So pancreatic cancer, 5-year survival rate of about 0. ovarian cancer, by the time it gets diagnosed, relatively poor survival rates. Lung cancer, marginal benefits. So the oncology drugs are this gets used quite a bit, but that doesn't necessarily mean that that we're getting better drugs or safer drugs. And if we look at moving for a time from oncology to what's the value, how much evidence are we going to get if we move from randomized controlled trials to more observational data? And this graph, or this chart, basically says that if it's to your right of 1, that observational data is giving you larger effects than randomized controlled trials. And so you can see here that virtually all of the summaries that they did show that observational data is not as good as randomized controlled trials. If you're approving drugs on the basis of observational data, your projection of how beneficial it's going to be is going to be much larger than it actually turns out to be. If you go from using phase 3 trials to phase 2 trials, you're again going to run into problems because oftentimes about 50% of the drugs that go from a phase 2 to a phase 3 fail in the phase 3 stage. So you accept drugs based on this preliminary data, and half of them, had they gone into a phase 3 trial, would not have survived. And this FDA report just looks at 22 different drugs for various reasons, for various things that didn't make it. In other words, the phase 2 trials looked good, and the phase 3 trials, these products failed and were not approved. And here is the reasons why they fail. And primarily, it's due to efficacy. The phase 3 trials just don't show that the drugs work. Safety is a more minor concern or more minor reason for failure, and that's because safety is more difficult to evaluate, the rarer safety problems in randomized controlled trials, simply because you don't have the numbers. So if you do 3,000 people in a clinical trial, your chance, anything that occurs less than 1 in 1,000 won't be seen. So you don't pick up these rare problems, and that's why drugs in phase 3 trials don't fail that often for safety reasons, simply because people don't see them. But they do fail pretty often for efficacy reasons. And the other problem that we're looking at is drugs going through smaller numbers of patients involved in them. So if you went through an expedited review process, you had 104 patients involved in the clinical trials versus 5 times that number for non-expedited. And you also took less time to get them through. And time is important because time to review the data plays into safety once the drugs are on the market. Now, I've got some Canadian information about that. In terms of the evaluation of how well these things work, once again, if you have smaller trials, you get larger treatment effects or apparent treatment effects. So if you've got your drugs going through an expedited pathway with 104 people, your expectations or the data from these trials is going to look much better than it actually turns out to be. So again, you have this drugs come onto the market with a lot that have gone through one of these with a lot more hype because they look a lot better than larger trials. Larger trials tend to show a much smaller effect. Surrogate outcomes are another issue. As I showed you earlier, surrogate outcomes are used much more frequently for oncology drugs than for anything else. And surrogate outcomes are things like time to progression. In other words, how long does it take for the tumor to get bigger? Things like length of time. They don't include how long do people live, and that's the main thing that we want to know. They include lots of other measures, time to metastases, time to people need further treatment, but surrogate outcomes don't tell you how long you're going to live. And for drugs that are approved on the basis of surrogate outcomes, we don't really know what's going on. So here we have, just look at this part. So this is all the oncology drugs approved in a period of time in the US on the basis of surrogate outcomes. And the tallest bar here is no survival benefit when they're finally able to evaluate it. And that's 50% of the drugs. Only, what is that, about 14% actually have a proven survival benefit. So you approve drugs on the basis of surrogate outcomes, but you're not doing anybody any favors. People are still dying just as quickly or slowly. And the other thing that we've found is that if you approve drugs on the basis of surrogate outcomes, that you think that they improve morbidity or mortality, frequently you're surprised and they don't. They actually kill more people. So there are a number of well-known examples. Did you ever have Encainide on the market here? This is a drug for cardiac arrhythmias that started to get widely used at least in the United States, and it turned out that it caused more cardiac arrhythmias and deaths than it prevented. Same with flecainide. We have, rosiglitazone for type 2 diabetes. When I remember being at a seminar 20 years ago, this was the next best thing to sliced bread. But it turns out that more people die of congestive heart failure due to it. So a number of these, erythropoietin being pushed to get hemoglobin up above 100, but if you get it above 100, there's a higher mortality rate. Finally, if you're going to have an accelerate or an expedited approval system, a lot of times, because the data is not particularly robust, the FDA will require post-market studies to validate the efficacy that is seen in preliminary data, or to look further into safety information. But these data or these studies are often not started in a prompt manner, or they're delayed, some of them. So you have, at the end of 2011, out of 387 trials that were required, 271 of them had not yet been started. Now, some of them because the drugs had just been approved and the companies didn't have time to get them going, but a lot of them were just being delayed. And I'll come back to that again when I talk about Canada. Here is data that looks at what happens when you speed up the approval of new drugs. And 1992 is the key date here, because that's when the US first passed what was called PDUFA, which allowed the FDA to collect user fees from drug companies, because the US Congress wasn't funding the FDA to the extent that it should have been. So PDUFA allowed the FDA to collect user fees. User fees are currently about 50 or 60% of the operating budget of the FDA, but at the same time, the FDA had to commit to approving drugs within a particular, or doing the review within a particular period of time, 300 days, and they had to do 90% of all of the submissions within that period of time, and if they didn't do it, then the next time when PDUFA came up for renewal, and it's renewed every 5 years, they might not get the kind of increases that they were looking for. So here is this looks at the odds ratio of a warning or withdrawal post-PDUFA. And this is pre-PDUFA, the odds ratio, and post-PDUFA. So there is a much greater chance of a drug that came onto the market after PDUFA acquiring a serious safety warning or being withdrawn from the market because of safety than there was before PDUFA was passed. So although this is does not establish a causal relationship, there is an association with faster approvals and more safety problems. And this also turns up in another study by a guy named Turner that was Carpenter, published in the New England Journal about 6 years ago. And what he looked at was what happens to drugs as they're approaching the deadline. So within the final 60 days of the 300-day deadline, drugs that are approved in that time period versus drugs that are approved either before that final 60 days or drugs that go over the deadline. And what he found was that there was a 5 times higher chance of drugs approved in that final 60 days acquiring a serious safety warning than drugs approved not in that particular time interval. And again, the speculation was that the FDA reviewers were starting to get worried that they were going to exceed the deadline too often. You can run into problems getting money the next time it's up. So they missed information because they were speeding up the review to avoid going over the deadline. The issue around requiring post-market studies, again, is a concern. So here is a drug, I won't try and pronounce it, for TB, one of the first new drugs that had been approved for TB in decades. And this was approved on the basis of a surrogate outcome converting sputum from positive to negative when it was added to a standard TB regimen. So not a clinical outcome, a surrogate outcome. It actually, when they looked at the trial data, it caused 5 times as many deaths in the control group as in the treatment group compared to the control group. They still let it onto the market. And the post-market study to establish that it actually had a clinical benefit was not going to be required until 2022. So that's 10 years after it was put on the market. Okay, let's move to Canada. So Canada is less complex than the United States, and we only have 2 expedited approval programs. So one of them is the priority review program. This is the same as in the US, 180 days instead of 300 days. Companies are supposed to submit the full range of clinical data, in other words, all the way through to phase 3 clinical data, but the Health Canada commits to reviewing that information more quickly. And then we have this other thing called the Notice of Compliance with Conditions, and this is allowing drugs onto the market based on typically phase 2 trials, and then requiring post-market studies. So we don't use these things as often as the United States does. So the priority review program, about 1/4 of the drugs that Health Canada reviews goes through that. And the Notice of Compliance with Conditions, it's only a little more than 1 in 10 products. So how well does Health Canada do in using these mechanisms? So let's look at priority approvals first. So the data here is somewhat limited, but what we're doing is we're looking at 426 drugs that were approved in this 15-year period, and 345 of them you could find independent evaluations of their of how much of a therapeutic gain they were. And that came from either one of 2 sources, the Canadian Patent and Medicines Review Board, which is primarily a pricing body, but in order to establish a price, it looks at the therapeutic value of new drugs, or an independent drug bulletin called Prescrire. So out of these 345, Health Canada ended up giving a priority review to 91 of them, but only 52 were actually regarded as important therapeutic advances. So Health Canada, and this is looking at how well does a priority review predict significant therapeutic advance. And you can see there that Health Canada doesn't do very well. It's got a CAPA score. Everybody taking statistics? CAPA score of 0.4 is not terribly good. So Health Canada expends a lot of resources putting through 25% of the drugs quickly through its review process, but its ability to actually choose which drugs are going to be major therapeutic gains is not terribly good. I mentioned the Notice of Compliance with Conditions policy requiring post-market studies, and this is an earlier evaluation of, are these studies being completed? And so you can see that the red is the conditions haven't been met. So when were the drugs approved? So 2001, you had 2 drugs approved. One of them still hadn't met the conditions by 2014. Another one hadn't met the conditions that was approved in 2002, etc. And a more recent evaluation is here. So what we have is, by the middle of 2016, there had been 80 notice of compliance with conditions issued for 63 separate products. Some products had more than one notice of compliance with condition for more than one indication. So 41, half of the conditions had been fulfilled, 31 had not been fulfilled, and if you move over here, 10 drugs were being prescribed by doctors, have been on the market for more than 6 years without the conditions being fulfilled, and 3 out of those 10 had been on the market for more than 10 years without the conditions being fulfilled. So when doctors were prescribing these things, they were prescribing them in a vacuum because nobody knew whether or not they were actually going to work. Here's one that didn't get removed from the market. So this is Iressa for the treatment of lung cancer, non-small cell lung cancer, approved in the end of the end of 2003. Additional studies required. Studies come in February of 2005. No benefit from the drug. So it should have been, under Health Canada's rules, should have been pulled from the market, but it wasn't. 6 months later, restricted to patients who continue to benefit from the drug. Well, how do you benefit from a drug that has failed to show any benefit? Finally, 3 years later, Health Canada deemed the conditions to have been fulfilled because it was non-inferior compared to another product. So, should this drug have even been on the market? Let's look at Canadian data about the safety issues associated with drugs that have been approved on the basis of a traditional review, 300 days, that's the blue line, and a priority review, that's 180 days. And you can see there about a 1 in 5 chance if you go through a traditional review, in other words, 300 days, that the drug will have acquired a safety warning or been pulled from the market because of safety. But if it goes through a priority review process, then that is a 1 in 3 chance. Again, associations, but it doesn't appear that this difference can be attributed to either the conditions that the drug was treating or the mechanism of action of the drugs. Same thing with respect to safety issues between drugs that have gone through a standard review and drugs that have gone through a notice of compliance with conditions review. More safety issues if they've gone through a notice of compliance with conditions review. And the notice of compliance with conditions is supposed to be granted to drugs that, on the basis of preliminary data, look like they're really promising. And that's why they're allowed on the market more quickly. But when you actually look at them, out of 27 of these drugs, 19 had no significant new therapeutic value, 6 did, and 2 hadn't been evaluated. So the majority of drugs that are led on through this process don't provide any additional benefit, but are associated with greater safety problems. And if we look even further to first-in-class drugs, in other words, operating through an entirely new mechanism, how many of those are actually major therapeutic gains? And you can see that even for innovative, first-in-class drugs, the number is pretty small. First-in-class, in other words, does not mean that it's going to be a significant therapeutic gain. It just means that you've got a drug that's never worked that way before. So, what's happening here? Okay, so this is a review that came out a couple of years ago. Lloyd Sanson was commissioned to do this review of the TGA approval mechanisms. And in the report, there were 3 recommendations that I thought were particularly appropriate. So there is this pathway 3, expedited approval of a mechanism in certain circumstances. Recommendation 8, developing accelerated assessment of new mechanisms. And finally, recommendation 10, that if you approved new drugs on the basis of an accelerated approval process, that you come up with a mechanism for having post-market studies that are going to validate things. And according to somebody that I talked to yesterday, there is legislation now that's being reviewed by the Australian Senate to look at changing the TGA to allow for these things. So how well is this going to work in Australia is something which might be interesting to investigate. All right, so why are we getting more expedited approval programs? There are some country-specific reasons. So in the United States, it's really 2 things. It's the economic power of the pharmaceutical industry, and not just economic, but also political power. The industry is the top, I believe, lobbying, spends more money lobbying Congress than any other industry in the US. And as a result, you get congressional pressure on the FDA. In Canada, it's largely outside pressure. The pharmaceutical industry isn't nearly as powerful in Canada as it is in the US, and Canada limits the amount of corporate donations to political parties. So we're subject to a lot of pressure from the EU and the US, who are acting on the basis of companies that are domiciled in those regions. And then there are some common mechanisms. So both countries have user fees, and in the US it's explicitly connected to faster reviews. In Canada, it's implicit. You have pressure from patient groups, some of which are funded by drug companies to get drugs on the market faster. My wife usually jokes that the best way of getting a new drug onto the market in Canada is to have it on the front page of the Globe and Mail, the national paper, with some person who looks particularly photogenic, who's dying of something that this new drug is going to cure. And finally, at least in North America, there is also deregulatory pressure from a variety of right-wing think tanks. So the bottom line, these programs are used widely in both Canada and the United States, although more so in the United States. Approval under Health Canada's expedited programs is not a good predictor of significant therapeutic benefit. Commitment to post-market studies are delayed or neglected. Expedited programs lead to more safety problems, and industry pressure is probably the driving factor behind this rather than benefit to patients. So thank you very much. A fair number. Not all of them are around, but most of them, except for, I think flecainide, one of these two got pulled from the market, and proteinin, I think, got pulled. I'm not sure which others. You know, some of them, for other indications, are still quite valuable. So metoprolol is still around, widely used, but just not for that particular indication. See, there was one where the company convinced them that they couldn't do the trial. I'm not sure what the situation there was. One or two of them, so celecoxib was given a notice of compliance with conditions because it was felt that it might prevent bowel cancer. There was some early speculation, but it didn't work, so that notice of compliance with conditions was revoked. Some drugs, a couple of them ended up getting removed from the market for safety reasons, a variety of different things. Well, that's what Donald Trump said. So you can find headlines where Trump says that they're going to cut 75 to 80% of the FDA regulations in order to get drugs on the market faster in the US. And also, this will improve competition and lower drug prices. There may be pressure to get drugs on the market faster, but even the companies, a lot of the companies don't like this idea because it exposes them to more risk post-market. So there may be some of that, and there might be, so when Mark, I can't remember, started with Mark Mick something, who was the FDA commissioner, they reduced significantly the number of warning letters that were sent out to companies for illegal promotion, and that might happen. There might be less prosecution for off-label promotion. I don't know that they'll reduce standards for getting drugs on the market significantly. That certainly is a concern, but we'll have to wait and see. Well, because the US market is such a mess, it plays out differently. So Medicaid, which is the state-based program of health insurance for people at or below the poverty line, is required to pay for virtually every drug that's on the market. So they have no choice. Some of the insurers have what are called tiered formularies. So generic drugs have the lowest co-pays. Then there are brand name drugs that are preferred, which are the second level, and brand name drugs which are not preferred are at a third level, higher amounts of co-pays. The only two bodies that really are interested in how well drugs work and how safe they are the Veterans Administration. That's a closed market, and they actually have their own formulary. And then Kaiser, which is largely on the US West Coast, again, has its own formulary. But a lot of insurance companies do not actually pay for the drugs. They manage drug plans. And there's a big difference. This also happens in Canada. So if you manage a drug plan, it's the company that's paying for the cost. All you're doing is doing the bureaucracy. So you don't care how much drugs cost or how well they work, because you get a percentage of the total amount. It's only if the insurance company is actually paying that they start to get concerned, and that's a minority. Andrew has a problem. We look at his DNA and we figure out that drug X won't work on him, but drug Y will work on him. That's happened to a small extent. So we get that in breast cancer with women who are HER2 positive. I can't remember the name of the product for one variety of cystic fibrosis where we're getting that, where the drug seems to be giving people an advantage. It's only about 5% of the people who have that particular genetic variant. But the rest of them, it's difficult to do. So there was a program that was started in the UK for MS. And this was supposed to be a controlled introduction where they were monitoring how well people did, and if they didn't do very well, the NHS would stop paying for the drugs. And at the first analysis, people who were on the drug were not doing any better than those who were on placebo, but the NHS kept paying for the drug. So I think what we need to be looking at are controlled introductions of new products with the expectation from everybody that at a certain point, if you're not improving clinically, that we're going to stop paying for the medication. But that's politically a really difficult decision to make. When again, you've got people on the front page of newspapers or if you've gone on the market through a notice of compliance with conditions and you look at the drug ads, there is something in the corner, whether or not anybody pays attention to that. But by and large, I would expect that virtually no patients and very few doctors have any idea about this, because really most of the information is on Health Canada's website, which doctors don't look at. And even if you do, it's really hard to find anything. It's a very poorly designed website. No. It would be difficult to gather that, because very few drugs actually are approved just for pediatric use. I mean, you can think of a few. So the ones to prevent or the ones for lung disease in premature infants, the artificial surfactants. But there aren't a lot. I mean, cancer drugs, any of the anti-inflammatories for juvenile rheumatoid arthritis, all that would be probably based on adult data. A lot of those extra patent life is once the product's on the market, then companies will do the pediatric studies. So the drug has already been approved and they're just trying to extend their patent life. I'm not aware that that there are many that are done pre-market where they're adding on the patent life. What's I heard the legislation is it's going to be two parts. So one is that a drug has been approved in a country that's deemed to have a sophisticated approval process. So either the EMA, Health Canada, the FDA, and those drugs will companies will only have to submit a very small amount of data to the TGA. And then you've got the second category of breakthrough products, which will be approved on the basis of phase 2 trials. So the ones that have been approved in other countries there may be a large element of rubber stamping. But see what happens. The review by the Senate is supposed to be a 6-week review, I'm told.
So I'll close it up at that point. This is the second time I've heard Joel speak. Both times I've left very concerned about any issues.
Don't take any drugs and you'll be fine, Andrew.
Yeah. But also really pleased that someone's out there and shining a light to these issues so that we know about them and we're informed about them. So I'll leave you this, a small token.
Well, thank you.
Just get everyone to thank you for